fired up about how important lifestyle changes are for chronic disease. This portion of the workshop is to kind of bring that theory a little more in depth into everyday practice. Whether you have, well, this is more for now, instead of the quick bang for your bucks, this is how to have maybe a bit of a more in-depth conversation with your patient and getting them to make some changes. I would like to do a quick poll. It's a safe space, just you're gonna ask a question, just to get a sense of the room. Like, now, pretend before you heard this, maybe now you feel a bit more equipped, but before you heard this, how confident and comfortable did you feel being able to effectively counsel your patients in making lifestyle or behavior changes? How many did not really feel comfortable at all? That's fair. I didn't think that would. Yeah. Somewhat confident? Yeah. Cool. Confident? Right, middle ground. That's good. Very confident. Somebody like, I can do this. Yep, great. How many feel I should be giving this talk? I'm that confident. Hey, none of them come up. All right, that's great. Okay, so the first step in starting to initiate lifestyle modifications in your patients is to actually get what I like to call vegucated yourself, right? Just like you wouldn't tell a depressed patient, like, hey, just don't be sad, right? It's not helpful really or meaningful for a patient to say, hey, eat well or exercise more, right? That advice is just too vague. And if your patient Googles healthy eating, they're gonna get about 1.15 billion hits, all with opposing messages. And this just leaves your patient really confused because, you have the keto camp and you have the vegan camp and you have the high carb and the low carb, and they get so overwhelmed. They're like, wow, since those guys can't agree on anything and they're experts, then I'm just going to keep doing what I'm doing here in the standard American diet, and it's killing them. So we need to give them clear, evidence-based guidance, and that means we as physicians also need to know the science ourselves. So where do you start? Well, I recommend not starting with Dr. Google because he will give you the same 1.15 billion hits he gave your patients. So what you need to do is look for excellent evidence-based resources, right? You always want to base your recommendations in science, and you also want to make sure they make sense because there's also a lot of science out there, but keeping it simple and making sure it makes sense is two kind of good tips. And there are lots of practical ways you can bring this to life in your own kind of development of getting yourself educated. So there's documentaries, there's podcasts, there's books, there's apps. You could also go as far as what I did and get yourself kind of board certified if this really speaks to you through the American College of Lifestyle Medicine. And that's what I did for myself. Now to help you, I've created a very comprehensive page. I think I called it like Getting Vegucated. It's a very comprehensive list of resources I kind of collected along my journey just to keep note, especially when I had students, so that they could kind of use the same resources and I knew that they were getting evidence-based information. And then again, in 1 week, on October 8th, I'm going to actually do a follow-up kind of 1 hour lunchtime learning to answer any questions or lingering questions we have from today, or maybe some time you've percolated some new questions. But also then I'll go through some more in-depth, like some of the websites, some of the learning tools that I've used, if you're interested, to kind of get yourself more educated, and I can show you those websites. And websites you can recommend to your patients as well. So that's number one, so first step, get educated. The second is to ask, right? Once you begin learning how powerful lifestyle is in chronic disease management, I promise you, you won't be able to unsee it or ignore it. And you'll start to see opportunities everywhere. And so it's important to ask when possible. And I like to treat lifestyle, like I do physical activity, as a vital sign. So it doesn't matter what the visit is for what condition, whether it's, acne, or somebody's coming in with constipation, or somebody's coming in with, a new diagnosis of diabetes, obviously. There's nothing that I can't see value in asking about their lifestyle. And remember to ask with curiosity and kindness, not kind of judgment, because that can shut things down. So using like an open-ended question, tell me what a typical day of eating looks like to you. And the benefit for this is twofold. It builds rapport and it helps patients connect the dots between habits and their health. I'm kind of smiling because I feel like something's happening and you're all about to make a really good video to post on.
It's cheating.
change, right? Hippocrates, my bestie, again, said it well. If someone wishes for good health, one must first ask if they are ready to do away with the reasons for his illness, because only then is it possible to help them. You've probably seen this. No matter how much you can cajole a patient into doing what you think is best for them, if they're not ready, they're not going to do it. And so lifestyle medicine is about education, but it's also, first and foremost, respects autonomy of the patient. Knowing what will help them doesn't give us the right to push it on them if they are not ready, any more than we can force them to take a pill. So our goal is to meet patients where they're at, not where we wish they were, and then build from there. And this is the only way that change becomes sustainable. So the fourth kind of key tip is to adopt a coach approach. Now this is very different from what we learned in our training. So it requires a bit of a mindset shift, right? So instead of being the authoritative expert, think of yourself as a coach when it comes to lifestyle modifications, recommendations, right? Because in reality, we're not the experts in our patients' lives. Our patients are the best expert. They know where they've been, they know where they are, and they know where they want to go. So I often tell my patients, hey, I'm the GPS, you're the driver, right? So I'm going to suggest which route I think can get you there maybe quickly and safely, but you're obviously steering the car, so it's always up to you. And just like in sports, right? A good coach, they don't play the game for their team, right? They prepare, they guide, they encourage. Players are the ones who do the work on the field. So we have to respect that with our patients. They're the ones in the trenches in their day-to-day lives. So our role as a doctor in this setting is to offer some evidence-based options, help the patients kind of reframe their challenges, and then support them as they test out what works for them. And honestly, it's so liberating when I started practicing this way because it really relieved me of this pressure I put on myself to fix everything for my patient, right? Instead, what I was able to do was help empower a patient to recognize their own ability to help improve their health. And watching a patient have that aha moment, it was so gratifying when they take charge of their health. So I'd be remiss if I wasn't talking a little bit about motivational interviewing. And it is a huge topic, and it sounds like the Southwest Self-Management, I kind of walked by it on my way to lunch, like motivational interviewing, like you have some resources right in your own area. But motivational interviewing is an evidence-based counseling approach. We didn't talk before. He has no idea that I was going to put a plug there. I thought that was amazing that you offer that to clinicians. But it is an evidence-based approach, a counseling approach that helps patients really uncover their reasons for change, using empathy and curiosity and guided reflection. Because the best motivation doesn't come from us as prescribers, right? It comes from within the patient. And motivational interviewing really draws out that inner drive. It really looks at, for each patient, what matters to them. And the studies show it's just far more effective in creating lasting behavior change than us trying our best to convince them it's the good thing to do. So change talk is a motivational interviewing term, and it's basically when patients start voicing their own reasons for making a change. In their words, not in ours. And the research is very clear on this. The more a patient engages in change talk, the more likely they are to follow through with their actions. And that's why our role isn't to persuade, right? Our role in this setting is to create some space for patients to hear themselves say what matters to them, what they value, and then realize that what they're saying matters to them is not in line with what their lifestyle is up to. And this is what we refer to as the gap. And when they come to realize the gap for themselves, and it creates enough discomfort within them, they're more likely to make a change that sticks. And I think Lyle and Janet will talk a little bit about that with a family member more recently, actually. But this self-motivation is far more powerful than any advice we can offer. And while I don't have time to go over the whole MI toolkit, that's a whole course in and of itself, I do want to give you kind of the ORS framework, which is a really good kind of simple framework that helps guide patients towards change. So the first is, and by the way, handouts are coming, like they're all in here. I outline ORS. I give you kind of sample questions you can ask your their story. They're not yes or no answers, right? That's an open-ended question. So instead of saying, do you exercise? You might ask, hey, what kind of exercise, what kind of movement do you enjoy doing, right? Open questions explore where the patient's at, like their world and what they're living in right now. And it often brings out also what matters most to them. Affirmations are about empowerment, right? So it highlights their strengths, it builds confidence, even saying something small like, oh, it looks like you've thought about this before. This really shows that you care about your health, right? This empowers the patient, even subtly, that they could succeed if they really wanted to. And this sense of ability actually sparks some more change talk in a patient. And then reflections, their purpose is to clarify, right? So reflections mirror back what a patient is saying to you. And it helps them hear themselves in their own ambivalence. So, and in doing so highlights the gap. So for example, you can say something as you're conversing with a patient. So it sounds like you want to quit smoking, but it feels to you like it's your only stress relief, right? That clarifies the tension, the gap, right? And invites the patient to start to think about it and percolate and reflect upon it and then want to resolve it in their own words. And then finally, summarizing really puts focus on the actual behavior you're talking about. So it pulls together what you've heard and gently kind of points patient back to their goals. So things like, so you want to have more energy for your family, and you see that diet is part of the issue. Bridge the summary with the word and, not but. Because but can create a bit of defensiveness, but and kind of ties things together. So in short, ORF is really about kind of exploring and empowering and clarifying and focusing with the patient. And this can help promote change talk, which then helps promote action. And I didn't know about the Southwest Self-Management Program ahead of time, but there are some online resources you could use. Some are paid, some are free. There's links in the slides there if you're interested in learning more about how to do this with your patients. And then you're going to roll with resistance, right? So one of the hardest parts about behavior change is when your patients resist, right? The but, right? Our instinct as physicians and humans is to kind of push harder with our agenda, but this just makes them dig in further. And so in motivational interviewing, we do the opposite. We kind of roll with the waves of resistance, and there are 4 R's that can help us do this. So first is kind of resist that urge to kind of counteract with some kind of persuasion or argue with the patient. It's just not effective. Instead, reflect back what the resistance they just stated, right? So acknowledge their stated resistance. Let's call out the elephant in the room, and then reframe it with another open-ended question. So for example, if a patient says, I don't have time to exercise, I don't have time to move more, your traditional reaction or response might be, well you just try to make time? Like, how will you try to make time? Like, is there any way you can make time? But an MI approach would be like, it sounds to me that time is really tight, right? So you're now reflecting on what they just said the resistance is. You know, it sounds like there's a problem with time. What kind of movement could you fit into the day, right? So you're now like, you're pushing them, but just subtly. You're getting them to reflect and reframe. Is there something I could do? Like, yeah, well, she gets it. Like, time is tight. Like, do I have a minute that I could, run on the spot? Do I have a minute that could I park my car at work? Let them try to figure out what might work. And then the last R is if after a few attempts to reframe and they still won't budge, like, just say, that's okay, right? Like, remember, we have to respect their autonomy. Like, we cannot force change or shame them. I know you never would, but like, you can't give that air of like you're disappointed. It's all good, right? So, you want to leave the door open for revisiting things with them in the future. So saying things like, I'm getting the sense that this is not something you're ready to tackle right now. And that's okay, right? There's many people in the same situations, but would you mind if I connect with you or check in with you at a future visit? Because maybe something will have changed in the future. And sometimes things do. Circumstances change and patients might be interested. And they're kind of, wanting you to open the door to that. And in your handouts, there's a whole rolling with resistance kind of scenarios for each pillar. Like if you get resistance on certain pillars, just some catchphrases you can kind of use as well, if you find that helpful. So say a patient is ready to make change. You're like, yeah, you know what? I am ready. I just don't know where to start. What I found to work best, just like what Devin suggested, is don't start big, don't overwhelm, right? Start small. And the one thing I really like and I've used, and I think it works well, at least in my experience, was to say, I say to my mission, what's one thing? What's one thing you can manage right now, starting today? And the smaller and more achievable, the better, right? So it's a little shift on the SMART goals. I think SMART is great, but we don't have time. Just one thing really works well. And success builds with one small shift. It's like building with Lego, right? You sort of those little pieces, you put them together bit by bit, and the block can add up to a masterpiece, right? And the best example I can give is to highlight this one thing, and I'll never forget this. Is an encounter I had with one of my colleagues. I used to do obstetrics, and I was working with one of my nursing colleagues, and we were chatting, and she was kind of down. We were waiting for patients to deliver for the middle of the night, and she's like, man, I've been diagnosed with high blood pressure, and I know I need to change, but and physical activity was kind of her thing. She was an athlete before, and so she'd kind of gotten out of that, and she'd gained some weight. She's like, but I know 30 minutes I'm supposed to exercise. I just can't do it, right? So I asked her, I said, well, okay, sounds like your one thing is physical activity. Do you have 5 minutes? And she's like, oh, yeah. I'm like, okay, so do you think maybe committing 5 minutes, rain or shine, no matter what, you put your running shoes on every day, you go out in one direction, and you walk as briskly as you can in one direction. You set a timer, and when that 5 minutes goes off, you can keep going, or you can turn around and come back, right? And this is my triple story. I'll never forget. And so she said, you know what, I can do that. Yeah, I probably could do that. So COVID happened. I kind of ended up, switching gears and leaving my practice. I hadn't heard from her, and so mid-COVID, 4 or 5 months later, I get this text from her. She's also a friend. And she said, hi Amanda, I won't make a habit of texting you. I wanted to let you know that thanks to your help, I've lost 35 pounds. My blood pressure is 122/74. I joined CrossFit, and I hike 7 kilometers a couple times a week. I'm happier and healthier than ever. It all started with you telling me to go outside for a walk 10 minutes a day. Thanks a lot. And I will never delete this text. I still get so giddy when I see it because, and I still work with her now. Actually, she's transitioned to an OR, so I work with her. She's a boss lady in CrossFit. She is super fit. She found a new partner. She's literally living her best life. And I honestly, it wasn't me. That was the best part. It was this situation always reminds me, just like it probably reminds you, Devin, 4 years later, right? Now this is 5 years later for me. You never know what one thing sparks a fire for a patient. Just one thing. So if you can hit that sweet spot with a patient and watch them run with it, I promise you there is nothing more gratifying as a physician than to watch a patient take ownership and run with their health. Nothing. Just like a good coach wouldn't show up for the game opener and never show up again. This is pretty obvious. I'm sure you all do it because your family doctor's going to see your patients again. But when they come back, check in with them, right? Ask, how they were doing. And with each follow-up, if they get a test result back and their cholesterol is lower, get excited, over the top. Oh my gosh, you did this. Way to go. That's so awesome. You must feel so great. And not at 10 times out of 10, they'll be yeah, and I feel better too. Because that's also a sweet spot. When a patient makes a change because they think they know they need to, or they're scared into it, they make a change, but then this funny thing happens. They make change, and they actually feel better. And that becomes their own motivation. It just kind of feeds on itself. And then you don't even have to recommend anything. They start doing it all on their own. And if you come back and their commitment has dwindled, again, reflect with them, recognize their gap, right? Go back to your rolling with with resistance, and revisit those, kind of key points with them again. One of the final things I want to leave you with is this. Lifestyle medicine isn't just for your patients. It's for us too. And adopting these healthy behaviors in your own life will benefit you and your loved ones by proxy. And if you're hesitant to even start some of these with your patients, then be your own guinea pig and experiment on yourself. And once you experience the physical, mental, and emotional benefits yourself, I promise you, you will be far more inclined to recommend them with genuine enthusiasm into your practice. And that, at least, was certainly true for me. And the evidence is clear on this too. There was a 2009 study that showed that physicians who practice healthy lifestyle behaviors are more likely to recommend them to their patients. And then the CMHA posted an Israeli health study in 2013, and it said, patients were 13.7 times more likely to follow through on preventative measures when their physicians model the same behavior. And in a time when physician burnout is at its highest, there is mounting evidence that when we practice in self-care in ways that keep us well mentally and physically, we enjoy longevity in our practice, and we enjoy our practice more. So, what are some practical ways, again, that we can share this information with patients in our setting? So, one is strategically booking your patients. If you're planning to have a longer conversation with a patient, or you know the patient is interested, you can book them back. There's several ways to do this. You can book them at the end of your clinic, so that if you go a little over time, you're not worried about the patients lining up behind, or before a lunch break. The problem is you might end up shortening your lunch break. Or what I used to do is I would kind of cluster 2 half days a week where I booked 30-minute counseling appointments. So I would, if a patient was interested and they wanted to come back, I'd say, this is really important, let's get you back. And I would schedule, I had one evening aside a month and one afternoon clinic aside a month, and I would just book 30-minute visits. And then if they didn't fill up the same day, there's always room for same-day appointments, so I was able to fill those spots on the same day if they weren't already filled. But it allowed me time in 30-minute blocks to have these conversations. If you're going to do that, use those counseling codes, which I'm sure you're familiar with. The first 3 units, so the first hour and a half of counseling you do with a patient about it, and make sure you put the same diagnostic code, because so if they're diabetic, even if you're counseling them on cholesterol, it's the same lifestyle counseling. Use KO13, after 3 units, use KO33, because that's not in the basket. Are you still under that model? That model still exists, right? So you want to optimize your non-basket codes as much as possible, so you get somewhat remunerated for your work. Why did I get all number ones again? Look at this. Okay, I'll fix that. So using handouts. So this is what Deborah referred to. It does save you time. It gives patients clear next steps. ACLM, again, is a really great resource. I'm a member because I'm a member, so I pay an annual fee for my membership. If you're a member, you have access to even more handouts. So I've asked Michelle to create a free account just to make sure what kind of, I'm 99% sure the 6 pillar handouts are all free for everybody, but they actually have some really great assessment tools. So if you wanted to assess their diet in a quick, easy way, and you could probably get these, I'm not techy enough, but there's probably some way you can get them into your EMR. You can kind of click on them and score them. And they're validated tools you could use if you wanted to have a more in-depth conversation about one pillar. I know that might be if you're a paid member, but I told Michelle, see what's available, and if there's anything not, I'll try to pick out as many, and I'll just forward them to you. Shh, don't tell anybody I did that. Sustainable Diet is another online course for your patients. If your patient's really interested, it's a completely free course put out by Brenda Davis, who's a registered dietitian in the West Coast in BC, and sustainablediet.com, and it's a free online course on how to transition to a more plant-based diet. The goal is not to be 100% plant-based. The goal is to add more fiber, but this gives you some recipes and ideas on how to do that. And then PCRM is the Physicians Committee for Responsible Medicine. It's another great website resource in your handouts. They have an actual Kickstart app for a patient, and it is called the 21-Day Vegan Kickstart. Just emphasize, look, unless you're interested, you don't have to be vegan. I'm not asking you, in fact, I'm not asking you to be vegan, because vegan implies just not anything with a face or a mother. I don't know what the phrase is that they use, but vegan, Oreos are vegan, right? You want to use plant-based or plant-forward or fiber-rich foods. That's the kind of way of eating that Canada's Health Guide promotes. And if a patient does want to be 100% plant-based, please refer them to a dietitian so that they know they're meeting their optimal needs and they're getting their vitamins and they're taking supplementation for vitamin B12 because they can get deficient. Some more ways. If you're one of those creative people, create videos, posts, Instagram reels, and share them on social media. There are 2 orthopedic surgeons in Halton. I don't know if you've seen this website called Talking with Docs. They started this website because they kept having to explain things to patients again and again about post-op. It started just with orthopedic stuff. And then Dr. Brad Weaning especially got really in. He actually reversed his medical condition with his lifestyle changes, so he started to dig into the research, and he started to post videos about lifestyle changes, and then they started to invite different physicians in, and so it became this kind of, they created a YouTube video, and they have now 1 million viewers on it, and they're getting income from it, it's crazy, and they're super funny. I would highly suggest looking at their stuff. It's great. Paul Zalzal is the one on the left, and he is hilarious in the videos too. So they really bring it about, and they just make it's all evidence based. I've been on their podcast a few times. There's links to their episodes. Another thing you can do if you're not inclined, if your office has a space where you play the news, how about you take the news off? And I'm sure there's a way to do this, but could you run the rain activity? Just let it run, or pick out some of their YouTube videos, create a thing, and just have them running. So at least your patients are viewing something while they're waiting that could help them, rather than create a stress response. Just as another option I thought might be helpful. I do want to point out, if you're working in an environment like a family health team where you have access to our allied health, shout out to our allied health professionals, right? Our job is not to replace their hard work, but it is to help set them up for success with your patient. So sometimes when we're busy, we just refer to the dietitian. You're diagnosed with diabetes, let's go talk to the dietitian about 90% of your medications, and then it's a nature of the family medicine beast where we're forced into 10 to 15 minute boxes with our patients. But we're not setting our patients up for success with the dietitian if we're not first planting that seed of why this is important. It's kind of like when you're handing out the resource. So help, give a 1 to 2 minute reason why this is so impactful for your health, and set up the dietitian as the expert who can help you with recipes, who can help you manage your diet, who can make sure you're getting all the nutrients that you need. This is what they've done, right? So it sets them up for success, and it makes their job, at least in my experience, it made it a whole lot easier for them because they trust you. They have a lasting relationship with you. They may not necessarily have that with your dietitian yet. So you want to kind of set that up for them so that they say, well, my doctor's recommending this. It's got to be important because they do trust what you say. It also is important to make sure before ahead of time, and usually it's the case, but just make sure you're all on the same page with your dietitian, and that you are recommending the same things, which 9.9 times out of 10 you are, but just make sure. And then I want to talk, the last thing I want to talk about is shared medical appointments. So shared medical appointments for chronic diseases in the schedule of benefits, it is a way, if you were inclined to use group therapy or you're interested, it is a way that you can do this work. It's really fun to do if you like speaking in groups and leading groups, and it's remunerated a whole lot better. I first learned about it from Dr. Larry Schmidt, who was in this area, who's like amazeballs, right? Is he retired? I kind of lost touch with him. He's the best. I actually visited his practice. So he came to speak to a lifestyle medicine conference I went to a number of years ago when I was kind of figuring out how to do this more practically in my office, and just learning, and just starting on my journey of learning. And he talked about shared medical appointments, and what he did was he would bring in patients for 1 hour at a time, and he would bring them in, and 12 max, and he would do more informal kind of setting. So let's back up. I learned about it from him. Let's back up what it is in a little bit more detail. But by the way, it is groups are great because they weave in social connectedness as a pillar. You don't have to talk about it because it's already engaged. And watching patients start to learn from each other, make connections, patients used to start to kind of exchange numbers, they would trade recipes, they would support each other, and wow, that's so great. You'd share your stories of success or things you're struggling with. It was just so awesome, right? And very gratifying. So, but if you're going to use this code, there's some very key points. I have in your package sent the actual schedule of benefits page that outlines this. But, okay, first of all, sadly, it's only covered for 5 conditions. There's some workarounds I'll explain, but so only for diabetics, not pre-diabetics, which I think is absolutely ludicrous because so pre-diabetics, it actually really is the sweet, that's where you want to get them, right? But anyhow, people with heart failure have heart disease, but they should have had an episode of heart failure, so it kind of limits you in that sense. Hypercholesterolemia, so that's kind of our winner here. If you have patients who have hypertension, sometimes, but not always, they also have high cholesterol. So you can put them in the hypercholesterolemia basket. If they have heart disease, they're likely to have a history of high cholesterol or on a statin. Asthma, COPD, and then fibromyalgia, actually. This is key too. I've learned from my mistakes. If you're going to use this code, every patient has to have the same diagnosis. So when you have to enter the diagnosis, yourself or your biller has to enter the same diagnostic code. So choose which one you're going to use. And again, even if you want to combine it because you don't have enough patients interested, you can combine diabetics with high cholesterol patients because a lot of diabetics are going to have high cholesterol. Not all, but most. So you can kind of then, but you would put the diagnostic code high cholesterol, hypercholesterolemia as your diagnostic code. Otherwise, they won't cover it for the patients not included. The patient must be a member of your clinic. They don't need to be your patient, but they need to be at least covered. Their ongoing medical care has to be within someone in your group. Okay, so I was able to see patients that weren't my direct patients. There was a few that weren't my direct patients in the group that I ran. Patients must be pre-booked. It's not a walk-in or drop-in setting, so they have to be pre-booked. You have to have evidence of that in your schedule. So there has to be constant, your attendance has to be constant there, but if, say you're doing a nutrition session, you can bring your diet, if you have access to a dietitian or a allied health professional, or you're doing a stress management, you want to teach mindfulness, but you're like, I don't know how to teach mindfulness, I need it myself. You just need to be present in personal attendance. That might mean even you going in and out if you needed to do things in between, but you could have it led by an allied health professional. And then it does say this cryptic line of clinically appropriate assessment must be rendered to each patient. Dr. Schmidt kind of worked this around by having his nurse do a blood pressure and heart rate and weight on every person coming in, which for high cholesterol, like what clinically relevant physical exam could you do? So you get that in there, you have her enter it into your EMR, and it also gives you tracking because it's nice when you start to see blood pressures go down and weights, and then you can celebrate that, right? So that is how I cover that, and then, okay, so here are the codes. Again, I'm sending you a link, or I'm sending you the actual SOB sheet, but so just so you know, so it's per patient, per time unit. So you can see how it pays a lot better. So if you have 2 patients, you're getting $35.10 per unit. A unit is 30 minutes or the greater part thereof. So if you have an hour-long session, you're going to bill 2 units per patient if it's 2 patients. And the price per unit goes down, but it does end up working out to be the same. Okay? So even if you get a husband and wife in your office and you book an hour appointment, that's a shared, well, yes, that's a shared medical appointment. You do a physical exam on both of them. The spouse should be your patient though, so you gotta be careful. But you could theoretically bill that as a shared. I like to run a group. I ran a 6 group. Dr. Schmidt was more kind of laid back. He would bring the patients in. He'd bring in some recipes, like his dietitian bring in some recipes sometimes. I thought it was awesome. I'm Italian. I love to feed people, so I would actually demonstrate. I thought that was huge. Because when patients hear more plant-based, they're like, more salad? Mm-hmm. But I would go and I'd bring my Instant Pot or my hot plate, and in front of their very eyes, I would, with some simple ingredients, make a recipe, let it cook in the Instant Pot or the air fryer. I made French fries one day for them, and they were all super stoked. I created a program where I would teach I walk them through the 6 pillars. I would teach a certain thing about, say, nutrition. I talk about unprocessing your diet, and then we would share a little snack while they, and that would happen in ours were about closer to 2 hours. So again, if you're willing to do that much, I took my half day, and I just did that. So I would do it I used to have an evening clinic, so I'd work an evening clinic, so I had that kind of morning and afternoon off, so I would do it on that half day in the morning, then I'd have my afternoon to do paperwork at the office, and I'd just run my clinic at night. That's how I managed it. But you could also, Dr. Schmidt just brought people in, and he said, okay, what kind of questions do you have about lifestyle? And then he would go through using nutritionfacts.org, Michael Greger. He's a physician in the US who does a lot of videos. It's in your, it'll be in your handout, the link there, on the resources page. And he would Google, so the patient had breast cancer. He's like, okay, let's look up breast cancer. like soy and breast cancer. Big question. People are worried about soy and breast cancer. Soy, breast cancer, and he'd look it up. They would watch the video together and they would talk about it. That's it. Very simple. It doesn't have to be really, really complicated. I like to make things complicated because I'm a little OCD. So I created a little kind of program, but you don't have to do that to make this work in your office. And again, billed per patient, and it's out of basket. It pays 100%, which is good because at least you're getting remunerated. And instead of giving the same message 8 times, you're giving it to 8 people at one time. So it's a little more time efficient. The only other thing is that if they say, Doc, I have a sore throat, would you mind checking my throat? You can't bill that same visit. You can't bill the same physician can't bill that visit on that same day. So you can do the assessment, but you can't bill for that AO7, for example. But that's okay, just bill your out-of-basket code. Any questions on this part? Okay, now I want to introduce, I kept looking to my side to these 2 wonderful people. I'd like to introduce you to Janet and Lyle Killens. This lovely couple were my patients in my practice. They ran through my 12-week program. I called it Welcome Home, like welcoming home and good health into your home. Anyway, they were my guinea pigs, them, and there were 12 in my group, so I took 12 people. And they were kind enough to share their journey. Before I do, Lyle was very kind to let me show kind of what his story was, where his health was, and where it ended up by the end of the 12 weeks. So Lyle, this is back in 2019. At the time, he was 71. Am I right? I have to do math. It's not pretty. He was diagnosed with type 2 diabetes. He was not on medication. He was at the diet controlled stage, although we were kind of flirting with medications and he was resisting. He was confirmed with an OGTT. He had a rising hemoglobin A1C. I'll show you those numbers in a moment. He was diagnosed with high cholesterol. He was on atorvastatin. He had hypertension, and he was on amlodipine and quinapril 20. He also had a history of pituitary adenoma, diagnosed 5 years prior. They had sized it, and he was on lifelong prednisone, testosterone, thyroid supplements as a result. He had been asking me, prior to starting the group, if we could increase his testosterone supplement because his level was a bit low, and I'll show you that as well. So a little begrudgingly, I mentioned the program to Lyle, and then I shrewdly mentioned it to Janet, and Janet was like, yes, we are in. And Lyle was like, okay, I'll do this too. I'm just joking. He was a ready participant. But Lyle honestly was, in my group, was probably the one who asked me the hardest questions. He pushed me on the evidence a lot because I was introducing information that he had not ever heard, and he would kind of sit with and then ask questions about. So he was my most prudent student, but the proof's in the pudding, so chia pudding. So this is his numbers, this is his graph of his blood work on our EMR. So you can see here where we started is the arrow. So the lowest fasting, sorry, by the way, since 2015, the lowest fasting glucose he had was 6.3. So in January, you see that spike. He was up to 8.3. That's January 2020 is when we started the sessions. I thought New Year is a good time to people. By May 2020, he was down to 5.8, essentially normalizing, almost normalizing his A1C. And this, sorry, normalizing his fasting sugar. Sorry, his A1C, he normalized. So in January 2020, he was 6.3. By May of 2020, post-course, he was down to 5.6. His LDL, I mean, look at that drop. It's like a stone. So he dropped from 3.05 to 1.91. Yeah, I think I have a slide saying what we did with that, but he's maintained that, and he'll tell you. I don't want to steal his thunder, he did. His triglycerides drop like a stone as well when people start to really unprocess their diet and move more. So January 2020, 1.88. He went down to 1.36. And then his testosterone, I didn't expect this, but he had the blood work he needed to do for his endocrinologist, and his testosterone, which was low, actually, it jumped into the normal range, and he hadn't changed anything in his dosing. So it had an unexpected perk for him. So in summary, 4 months into changes, he had finished the course. By this point, he was eating whole foods. He had eliminated dairy because for him it made sense based on some of the evidence I presented. He was predominantly, but not 100% plant-based. He just kept his meat portions very small. He kind of alluded back to the days when he was a kid, and he said, "Oh, I didn't eat a whole lot of meat. I had a lot more on my plate that wasn't meat." This was key for him. I think this was his magic. He started walking 10,000 steps every day. His quote was, "I feel amazing. I'm going to do this for the rest of my life," and he'll tell you if he has or not. And then he started getting dizzy. So I took I had him take his blood pressure readings, and they had dropped 103 and 117 over 60 to 70. So pre-course, his home readings were about 143 over 75. And so we lowered his amlodipine to 2.5, and we continued quinapril. In June, I called him, said, "Hey, how are your home blood pressure?" We're in COVID by this point. I called him, "How are your blood pressure readings?" They were still normal. In fact, still on the low end of normal. He wasn't getting dizzy, but he wanted to try stopping it altogether. And I said, "Are you still doing your stuff?" He said, "I'm still doing my stuff." So we did it. And he came off of amlodipine altogether, and he maintained his blood pressure. His weight dropped from 103 to 93. His BMI dropped from 34 to 31. And he was unable to measure his waist size because of COVID. We finished the course virtually is what happened. But his wife had to buy him 2 new belts because he had to add more. So he was very happy with himself. Okay, I'll leave that for a moment. So I would just like to give the floor to Lana and Janet. It's really good to hear a patient testimony, a patient's perspective as to what he went through. And I'll leave the floor to them, and then we'll have some time for questions. Lana, Janet.
Thank you. My wildest dreams, I was saying Amanda at her last horse kind of thing. We were asked to prepare some meals that we thought for the group that would be beneficial and that they could buy into who might be interested. I'm not a cook by any means. I like to eat, but I'm not a cook. They asked me to make this oatmeal breakfast. What should I say? Won't call it a dessert, but it looked like a dessert. And I made it, and I never thought in 1,000 years any of the 40 group would eat it, but most all ate it and said they enjoyed it. I'm sort of at the stage here now also saying that I can't believe I'm standing here in front of you. It's a pleasure. I'm honored. I thought I might try and do this. Amanda has most of the information that I would probably like to share with you. But I thought it might be interesting to share my background and why I was somewhat hesitant to jump in with both feet in this course. I'm from a farm background. My parents had the farm before me. I actually owned the dairy farm for 6 years, or 16 years I should say. And we had a typical farm background. I didn't know there was pasteurized milk till I was 20. Totally raw milk that we had. In my childhood days, what we would do, or I'd see my parents do, there would be animals processed for it. We always had lots of feed, but never excess. And I can remember there was never one person in my family that was considered the least bit overweight. But having said that, I'd like to go back in my family history. My paternal grandfather died in an accident when he was 42. My grandma, she was 76, died of a heart attack. On my maternal side, not great. My grandfather had diabetes. He ended up dying of a heart attack when he was 60. Fortunately, my grandmother on the other side lived to be 95. But what sticks in my mind is she had great health till the end, except in physical breakdown when she was 95. And I so recall our last visit with her. We said, "Well, we'll see you later, Grandma. Take care." And she says, "I hope not. This is no way to live." So that stuck with me. But anyway, my dad also, early on in his life, was treated with high blood pressure. And he thought, well, that's something I'll deal with. He was a politician, deal with many stressful situations. He ended up having a stroke when he was 52, passed away when he was 60 with a heart attack. So based on that family history, I was always in the back of my mind knowing that I'm going to need some kind of medical care. And so when I was about 50, I decided, well, I should maybe go to my family doctor and have this done. So I went there, and the doctor at the time, predecessor, Dr. Marrone, suggested, well, your blood pressure is a little bit high. Maybe we should start you on 20 milligrams of quinapril. Fine, that's easy, I can take a pill a day. Shortly thereafter, was a cholesterol situation, so I went on the Lipitor. I must admit that I like to eat, and I was a wee bit overweight. I was running 2 jobs at the time. Shortly thereafter, I bought a hockey team, and I was involved with that, so let's say there's a little stress in my life. I also, in my family, I have 5 siblings, 2 brothers, 3 sisters. Unfortunately, one sister passed away with complications from a gallbladder surgery. The other 4, 2 brothers, 2 sisters, are currently all dealing with diabetes and are all on medical treatment. So after taking this course with Dr. Marrone, I suggested maybe there's something, lifestyle, that we could change or you might want to look into. And being like I initially was somewhat strong-headed, I guess, they'd say, no, it's totally hereditary. And I still feel bad to this minute that I haven't got the message across to them, but maybe someday that'll change. Dr. Marrone alluded to my pre-diabetic situation, and the one thing I guess that stands in my mind that I told her, I'm not taking metformin, I'm not taking it, I'll do whatever. So fortunately, eventually her program came along, and now I'm not even pre-diabetic. I have been testing from time to time with my family doctor, but I've progressed on that one, so it's not even a consideration. 15 years ago, I guess it was 15 now, it wasn't 15, 11 years ago, I'm going to say, I hit a wall physically with many conditions that sort of compounded all at once. I had major stomach issues. If I looked at food, I couldn't keep it down. I lost 65 pounds in that time frame. I was treated for H. pylori. Different things, they could not find the problem. I had kidney issues, supposedly I had kidney stones, kidney issues that I dealt with. I was in hospital over a weekend. And that just kept going on and just getting worse and worse. Finally, I had a call from Dr. Marrone. She had been on leave, and she called and said, I understand you're having a few issues. And I said, well, I'm feeling all right today, not too bad kind of thing. She said, well, I want to see you. I'll be in the clinic after 9 o'clock. I have my patients booked and processed from there. And so I said I'd go there, and she looked at me and said, you're not doing well. Thanks to her, and I owe my life to her at this point. She said, I'm going to do everything I can, so she had an arrangement with specialists for Monday morning. So it was Dr. Prodger's his name, specialist. He booked appointments for me the next Monday. Fortunately, I didn't make it there. I was admitted to hospital on the Wednesday. On Thursday, he did emergency surgery, and when I saw him on Friday morning, he said, if you didn't have the constitution of a horse, you should have been dead 24 hours ago. So that was the situation. So anyway, we went on a few times after that. I somewhat got a wee bit better, but not really. And then 3 months later, I was diagnosed with a macroadenoma, and had treatment for that. I've had 4 surgeries since then. I'll be doing radiation. Fortunately, it's been benign, but it's something they cannot totally correct, and we'll deal with that in January when we get there. So my appointments then continued with Dr. Marrone, feeling somewhat better, and she knew my situation very well, and she says, maybe you want to consider this course that I'm putting on. And well, what's that? Well, it's lifestyle-based kind of thing, and based on your situation, I think you can see some benefits out of that. She's right, I was rather reluctant, and unbeknownst to me, Janet had said yes to the course already. So I was lucky to be one of the first 12 involved. I was dealing with a lot of issues that I thought were fine, but obviously they weren't. So we took the course, and I was a doubting Thomas. There's no doubt about it. I thought, you know what kind of propaganda is going to be put on me that I have to digest? So anyway, I did go to the first session of the course, and a few things seemed to make sense to me. And then the second session is when it really clicked into me. she did her, is it pre-breakfast oats? Or?
Overnight.
Overnight oats, sorry. And she had said, bring this container, and it wasn't so bad, just oatmeal for breakfast, but she had everything you could think of, every kind of fruit there was maple syrup, there was honey. Oh, wow, this is like a feast. And so,
In small amounts.
she wasn't watching what I was doing. Anyway, I thought that was great, and then as she alluded to, the next session indicated that, yeah, we're having French fries. Perfect. Well, she put them in a deep fryer, but they were...
No, air fryer.
Air fryer. Not deep fryer. I'll get to that. I didn't know there was anything like an air fryer, but they're only deep fryer for French fries. But anyway, I clued in, and at that time I thought, you know what, maybe at least I could do the walking part of it. And I started walking immediately after the second session, and when I take on something, I don't just sort of walk in with baby steps. Whole hog, I'm into it. So I started with the 10,000 steps a day, still do 10,000 or hopefully more every day. But what I found extremely beneficial, and I'm going to back up a little bit, one motivating factor that I saw, the second day that I started walking, there was this mother goose, and we have a large pond, and she was sitting on a nest. And it was a horrible day, March day, wind, snow, a little bit of everything. And she had the wherewithal to sit on that nest and not move off of those eggs. And she sat there for a month, and I thought, she's got the wherewithal to sit on that nest, not move, because probably something good is going to happen. Not that she knows will happen, but something good will happen. And I thought, if she can do that, I can do that, and because probably something good will happen. That's pretty well. Also, the other thing that when I wake up in the morning, I find it so invigorating, and the nature thing. Outside, take a few deep breaths, make sure I leave my phone inside, nothing's going to bother. But you really get in tune with nature, and you really do, and you start to see things, feel things, sense things that I just overlooked before and never really saw. So then, after that, then it's the diet part that comes into it. Janet kept me on the straight and narrow on that. There was a few challenges, like experimental meals kind of thing. Some were really good, some were so-so, and some we haven't had again. So Janet looks after that part. The other thing that I did, I didn't mind having lunches at a fast food restaurant kind of thing. I'd stop in there from time to time, quite often. Since about that time, I believe if I've been to 2 of them since that time, which is over a decade now, I'd be surprised, and I really think that's helped me. So, another thing I'm proud of is my fishing buddies. For many, many years, we went fishing, and we didn't eat very well. We ate a lot, but we didn't eat well. So a typical day would consist of bacon and eggs, or pancakes with syrup for breakfast, bologna sandwiches for lunch, and then we'd have a fish fry, French fries, fish for supper. Then we'd sit around the campfire and pass a bag of chips around, or a few bags of chips. So that has pretty well stopped since I've had the experience, and I'd love to share it with my friends. So now I can guarantee you there's fruit and vegetables in most meals, and we use an air fryer instead of deep fryer for the medication-wise, nothing recently has really changed. I still have quinapril and Lipitor, 20 milligrams a day. I recently had a visit with my physician, and I suggested, well, you know, I'm really doing well. Why don't we just maybe discontinue that for a day or two, like lifetime maybe? And she said, why? Things are going really well. Why would we change now? So I guess I will be doing Lipitor and quinapril for the rest of my life. I just think that anyone that takes this course, or you people that maybe enlighten somebody, it's only beneficial. And no matter even if you take a weeny little bit out of each session kind of thing, it'll go to help you. I'm now 77 years old. I feel great. I'm looking forward to life, and I just want to say that lifestyle change has been so beneficial to me, and I'm just so thankful and blessed that I was able to be a part of it. So thank you.
do some reminders about certain diet things. But the rest, you know, we're pretty much on board. My journey is a little bit shorter than Lyle's because I haven't had the same health issues that he's had. My background is physical health and education, so I've had an interest in that my entire life. And I've brought in friends and had conversations with folks about diet and exercise and activity for a very long time. And I was ecstatic when Dr. Amanda said, you know, she'd like to do this lifestyle course, because I knew it would be beneficial for me, as well as Lyle and other people around me that I happen to love. And I have a goal, and I think it's important if our physicians can ask, what is it you want out of life? And my goal is to have some quality of life. I have 8 grandchildren, and I would like to spend time playing with them. So that is my goal. So what do? We do these lifestyle kinds of courses. My improvements, the time that Lyle described his illness with the macroadenoma, I went through about 10 months of high stress. I had a fairly stressful job the last number of years in my work, but that 10 months was very difficult, and I ended up with Takotsubo. They're now diagnosing it as anxiety, which is fine as well. So I have to recognize my triggers when I get into a situation where I'm having a little bit of pain or I'm finding myself getting wound up, and doing mindfulness, which is what Amanda had worked on with us. It's one of the pillars of managing stress. So I do deep breathing and some mindfulness, so I'm really pleased with that. My activity level is still up there. I do an online course with the Niagara region. It's free. It's mostly for seniors. There's balance, there's weight training, there's cardio. So I do that twice a week with them, and sometimes we can take an extra course. I also do walking. I'm not at the 10,000 step right now, but it's the goal that I'm going to work towards increasing again. And our diet, we've eliminated most dairy. That was really hard for Lyle. We went for a whole month without butter, which was traumatic for him. And I do use butter now, but it's very sparing. I do not use margarine or any of those other products. I use a little bit of butter. We do not really have ice cream. We don't have cheese. I don't do yogurt anymore. So we pretty much eliminated dairy from our diet, and I think that's been very beneficial for us. We've decreased meats, and we've altered the meats that we have. Less red meat, more white meat. But smaller amounts as well, and we have increased our legumes and vegetables a lot. One other story I'll tell you is what we do, other people watch. We have lots of friends, we have a good-sized family, and one of my sons, he has a very stressful job. He was overweight. He works very hard. He parties very hard. And he likes to do hunting and fishing. He was finding that he couldn't do the walking and carrying the hunting equipment and gear. And so he was not happy about that. He went into the doctor's office, his family physician, and he got some results that he really didn't like. It had something to do with hypertension, cholesterol, being overweight. So he decided at that point that he would do something about it. And I think probably we're part of the impetus for him and him seeing our success for him doing this. He has, and it was over a year ago he started, he has lost about 60 pounds. He stopped partying so very hard. And his sleep is better. So he is doing well, and he's been able to maintain that now for a year. So,
Dizzy, right?
oh yes, he was on blood pressure medication, and he was exercising, got dizzy, so he was taken off of the blood pressure medication, and I believe maybe the cholesterol as well. So eliminating medications for me is very important because I know there are side effects. Side effects that I would not want to have. So for us, that's a real blessing too. I've been advocating, and I talk to friends and I talk to family, and one of the things that I did about 2 years ago, I wrote a proposal for a grant to get money to bring Amanda and her program to our hall. And it was a federal grant that I went for seniors, and we got it. So we ran a session with about 50 people who signed up. We did live streaming, so we had some people signed up for live streaming. We created a website where everything was uploaded to a website so that when the participants went home, they could go on the website and review, I guess, the videos, the YouTubes that we had created, pick up on many demonstrations of different foods and what have you. So those were uploaded as well, and all the recipes, resources were all uploaded on the website. It was a really successful program that we ran with about, I think we had about $15,000 where we could run this program. It was an 8-week program. Since then, I have written another proposal, and that was to the provincial government, and that was about a year ago that I wrote that. We were not successful, but I will try again. I will keep my eyes open for different opportunities so that we can bring these kinds of programs to the people in our community. And to this day, I've still got people coming up saying, when are you going to have another program? I have friends or I have family members that really should be taking part in these kinds of programs. Or I had real success, diabetic, and I have decreased my medications. So these are people in our community who would really like to see us have these programs again. So successes. Okay, just talked about that. So there are some learnings, some big learnings that I have had as a person being in the program and as an advocate. And one of them is making change is not always easy. But I think that Amanda has given you some real good tips on how to approach people like me who can get pretty stubborn or get pretty defensive if we're not cautious. And I'm sure that you already have some of those skills in your bags. Once I have learned, or once we have learned some scientific facts, it's hard to ignore them. Such as if you exercise X number of minutes a day, it will increase your lifespan by, what was it, 7 years or something? Up to 7 years. Now who doesn't want to live a quality life for another 7 years? So giving us these scientific facts, you can't forget them. They're there. And sometimes they make me feel a little bit guilty if I'm going to go for another piece of pie. I'm thinking, no, I probably really shouldn't have that because I know what my goal is. I learned that I am in charge of my health. What I choose to do makes a difference. So I'm very confident about that. I know that I can make myself healthier, or I can let it all go and not be healthy. And my choices are not just lifestyle choices anymore. They are more lifelong choices. And that's something that I've been thinking about in the last few months. So these are lifelong things because I can't forget what I've learned. And so I say to you, as healthcare providers, you have a lot of power. You have a lot of power in the palm of your hand, and just by planting a seed, just by asking that open-ended question, getting people like myself and Lyle to think about our health and what our goals are going to be for life, you can help with those changes. So I thank you. And I love our medical system. We've had really, really good luck with it. So thank you.
They have been, they're on fire, really have been forces in their community to try to